Good morning, everyone. Good morning, great nurses. Today we will have an article discussion to keep ourselves abreast of the new knowledge and new current research findings. The Nursing Evidence-Based Practice and Research Council is honored today to present a journal club entitled The Design and Development of a Multifactorial Falls Assessment in Falls Prevention. I hope this article will be utilized in the evidence-based practice of nurses in the future. So without further ado, I will be introducing to you the speakers of today's event. Don't forget to enter your name and badge number and unit in the chat box. And at the end of the presentation, there will be a journal club critic. I will send you the link. Please put your name correctly and email, because after that we will be sending e-certificate. For the presenters, Kenneth Jose, Devi, Pauline Diploma, Puff July Di Medios, and Juliet George are all from LTC. Melvin Rubino from 10th floor, Julie Tomas, 7th floor, Ahalia AL, and Rocky Rajan are both from 11th floor.
Hello, good morning. I'm Melvin Rubino from Medical Unit 10th floor. So I'm one of the chargers in 10th floor. So for our journal club, we will be discussing the design and development of a complex multifactorial falls assessment intervention for falls prevention, the prevention of falls injury trial, or the PREFIT. So for this article, for the journal impact factor, the BMC Geriatric is an open access journal publishing original peer-reviewed research articles in all aspects of the health and healthcare of older people, including the effects of heal, the care systems, and the policies. So, as you can see in the presentation, what does the SGR means for this article? So, SGR is the journals. It is also a prestige metric-based ideas that all citations are not created equal. With SJR, the subject field quality and reputation of the journals has a direct effect on the value of the citation. So for this article, it belongs to the Q1. According to the SGR, the most prestigious within a subject area are those occupying the first quartile of the Q1. For this article, it's having a 1.37 scores. So if you have more than 10 or greater scores, you belong to the excellent, and 3 will be flagged as good, and the average score is less than 1. So this is a rule of thumb. So scientific journal ranking. So according to the Simago journal rank, it's an indicator that measures the scientific influence of scholarly journals, that accounts for both the numbers of citations received by a journal and the importance or prestige of the journals where the citations came from. Next will be the PICO formula. So this is a mnemonic used in evidence-based practice to frame and answer a clinical or healthcare-related questions. The PICO framework is also used to develop literatures search strategies, for instance, in systematic reviews. So PICO, it stands for the patient, problem, or the population. I for the intervention, C for the comparison, and O for the outcome. So for this article, the population will be the community dwelling adults aged 70 years and older. They are all recruited from the primary care in the National Health Service in England. And for the intervention, a complex intervention was developed for inclusion within the Prevention of Falls Injury Trial, or the PREFIT, a multi-center pragmatic RCT. And for the comparison, the clinical and cost effectiveness of three alternative primary care falls prevention interventions: the advice, exercise, and multifactorial falls prevention, or the MMFP, on outcomes of fractures and falls. Outcome is the development of high-quality, evidence-based, multifactorial falls assessment intervention for falls prevention. The Prevention of Falls Injury Trial, or the PREFIT. So, where it is ranked? So, this article belongs to the level of evidence, level 1. So, as per SGR, it belongs to the top 25 articles. It belongs to the randomized controlled trials, or the RCT. RCT is a type of scientific experiment or intervention study, as opposed to observational study, that aims to reduce certain sources of bias where testing the effectiveness of a new treatment. This is accomplished by randomly allocating subjects to two or more groups, treating them differently, and then comparing them with respect to a measured response. One group will be the experimental group, and the other group will be the controlled group, where the two groups will receive two different treatments. So I will pass the stage for the next speaker. Thank you.
I am Dahi from 11th floor. Okay. I will discuss about title, author, and year of multifactorial fall prevention. So the research article is the design and development of complex multifactorial fall assessment intervention for fall prevention. The prevention of fall injury trial. This one PREFIT. So the author is Julie Bruce. This one published on 2017. Okay.
Hi, good morning. I am Ahilya from 11th floor. So today I am going to discuss about the aim of this multifactorial fall prevention. So the primary objective of the study is to establish the comparative effectiveness of three primary care fall prevention intervention: advice and advice supplemental with either or exercise, or MFFFB. That means.
Thank you, Ahilya. Now I am discussing about the background of fall-related injuries. The World Health Organization ranked fall-related injuries as the third leading cause of years lived with disability. Risk of falling and sustaining injury increases with age. Data from the Centers for Disease Control and Prevention shows that injurious falls are a leading cause of death in those aged 75 years and over. Fall death rates in the US increased 30% from 2007 to 2016 for older adults. As shown in the diagram, in 2007, from 46 death rates per 1 lakh, it gradually increased to 60 death rates per 1 lakhs in the span of 10 years. If this rate continues to rise, we can anticipate 7-fold death every hour by 2030. Falls have a multifactorial etiology and numerous risk factors have been identified, including impairment of gait and balance, visual impairment, syncope and cardiac arrhythmias, polypharmacy, food disorder, and environmental hazards.
The Prevention of Fall Injury Trial, or PREFIT, compares three interventions. First, advice alone. In brief, the advice alone intervention is the Staying Steady information leaflet published by Age UK. What is this leaflet all about? It is a simple guide that you can do to help you stay steady on your feet, whether you're active and fit, or having difficulty walking and getting around, or are worried about falling. This guide, the Staying Steady Guide, improves your strength and balance. Second, exercise. This exercise intervention is based upon the Otago Home Exercise Program, which targets your lower leg strength, balance, and walking. It is a series of exercises delivered by the physical therapist. Third, the MFFP. MFFP intervention, which is the focus of this manuscript, MFFP, or multifactorial fall prevention, is based on a primary care based screening approach determined from a short completed falls and balance screening survey. In MFFP, there are 8 risk factors checked to identify clients or patients at risk of fall. It will be discussed further in the next few slides. Systematic reviews of fall prevention programs. There are now over 100 published trials investigating the efficacy of fall prevention initiatives, but many of these studies have small sample sizes and are low methodological quality, or the extent to which the design and conduct of the trial are likely to have prevented systematic errors or bias. In 2003, a Cochrane systematic review, it is a type of trial wherein specific methodologies is prepared and being maintained. So they included only 4 good quality trials. First, investigating the effectiveness of multidisciplinary. Second, multifactorial. Third, health or environmental risk factor screening. And lastly, intervention programs. These trials suggested a 27% reduction in falls for unselected older populations in the community. In addition, across 5 trials observed, there is also a decrease by 14% in risk of falling for those older adults with a history of falling or who were selected because of non-risk factors. However, there was insufficient evidence to know whether MFFP programs prevented fall-related injuries. Since publication of the original MFFP studies and the Cochrane Systematic Review, there have been several other well-conducted large trials in the UK and Netherlands investigating the effectiveness of MFFP. These studies, somewhat surprisingly, found no evidence of fall or fracture reduction. Additionally, recently updated high-quality systematic reviews concluded that MFFP might be substantially less effective than previously thought and possibly not effective at all.
Hi, good morning. I am Julie Thomas from 7th floor. I would like to discuss about methodology for multifactorial falls prevention. The PREFIT study is a multi-center, pragmatic cluster, randomized controlled trial with the unit of randomization being the general practice or cluster rather than individual study participants. The cluster design has been selected to avoid contamination. It would be difficult for GP to randomize individual patients to different treatment interventions in the same practice and to study uptake of different interventions. Hence, a cluster design was chosen. Clinical trial randomization means the patient's information is entered into a computer. The computer randomly assigns patients to two or more groups, helping to prevent bias. Control groups receive standard therapy and investigational group receives new treatment.
Does the trial have ethical approval? In the UK, all research involving data collected from NHS patients must be approved by Research Ethics Committee. The PREFIT study has full ethical approval from a multi-center Research Ethics Committee, or MREC, with additional site-specific approval from each participating regions. So, for 60 general practices across 5 NHS regions, people aged greater than 70 years old or older than the 70 years old are sampling frame. Mail invitation to potential participants, so 300 per practice. Participants recruited 150 per practice, and practices randomized 60 practices or 9,000 participants. So it's divided into 3. So practices, 20 advice leaflet only. So here is advice leaflet with cover letter from GP and follow up to 12 months. For the second one is 20 advice and exercise protocol. So advice leaflet and balance screening survey. Then those at risk invited for exercise therapy and also for follow-up after 12 months. Practices for 20 advice and MFFP protocol, advice leaflet and balance screening survey. Those at risk invited for MFFP assessment and follow up to 12 months. So for this setting, primary care in National Health Service or NHS across 5 regions in England. So study population, the trial recruited 9,000 adults over the age of 70 years old who live in the community, either at home or in sheltered accommodation. Of those recruited and consented to participate, GPs will then screen for risk of falls using a simple postal questionnaire. PREFIT study, participants will be referred for falls assessment based on responses to this self-screening survey. This patient group, therefore, may differ slightly from the usual patient referred for fall risk. So PREFIT study entry criteria. So patients age over 70 years old, live in the community at home or in sheltered accommodation. Third, person has life expectancy of greater than 6 months. Fourth, GP considers eligible for inclusion in the trial and has consented to participate in study. So referral criteria. Person has fallen twice or more in the last year. Person has fallen once in the last year and has balance difficulty, or person has not fallen in the last year, but they reported balance difficulties or other difficulty with particular daily basis or daily activities such as dressing, bathing, etc. Person not currently attending a fall service. So PREFIT falls risk assessment quick reference guide. So there are 4 risk factors. So first is the fall history. In fall history, ask about context, consider potential causes and consequences, and treatment action. Continue with full MFFP assessment. Second is the red flags. Refer to manual like fainting, loss of consciousness, any dizziness, any tongue biting or facial injury. The treatment will be consider referral to consultant, lead fall service or secondary care if red flags present. Third, gait and balance. Conduct timed up and go test. Observe for balance problems whilst walking or turning. Observe gait. Any shuffling or postural sway. And was TUGT completed within 14 seconds? So, for treatment for gait and balance, if problems with gait or balance, refer to physiotherapy for orthogo strength and balance retraining program. Last will be postural hypotension. Any dizziness or on rising from bed, check radial pulse rate and rhythm. Take lying and standing BP, preferred within 3 minutes of standing, and conduct ECG if irregular pulse or brady or tachycardia. Treatment advice about postural change if symptomatic, conduct medication review, and GP to assess ECGs. Refer to other services if underlying disease is suspected. I'm sorry, there are actually 8. So fifth is the medication review. So taking any meds to help you sleep or lift your mood. Check for any of the following, like hypnotics, anxiolytics, antipsychotics, antidepressants. Also, BP, arrhythmia, angina, Parkinson's, or prostate drugs. So treatment, conduct full face-to-face medication review, modify, reduce, or stop culprit medication if indicated, and provide non-pharmaceutical advice for treatment of chronic conditions. 6 is vision. Explore last time eyes checked. Conduct Snellen chart tests on all patients and record acuity for both eyes. Treatment, refer for optician for eye test if no test in last 12 months. If eye disease suspected, refer to optician and ophthalmology services. 7 is footwear and footwear. Visual inspection of feet on all patients. Check for corns and growing toenails and any problems with feet, example, pain, numbness, any history of diabetes. So conduct tests for numbness and proprioception if indicated. Refer to podiatry if indicated, and give Age UK advice leaflet if not already received. And last is environment hazards. Any use of furniture for support when walking, difficulty getting out of chair or using stairs or steps at home, any use of walking aids. So treatment, give safety at home tip sheet, raise awareness of potential home hazards like rugs, wires, etc., and remind to use lights if rising in middle of the night, and refer to OT if indicated.
Clinical guidelines for the assessment and management of falls in older adults. After piloting and modification, the final MFFP intervention includes 7 falls risk factors. These are the following: a detailed falls history interview with consideration of red flags, assessment of balance and gait, vision, medication screen, cardiac screen, feet and footwear screen, and home environment assessment. This complex intervention has been fully manualized with clear documented assessment and treatment pathways for each risk factors. Each risk factor is assessed in every trial participant referred for MFFP. A referral for assessment is based upon a screening survey to identify those with a history of falling or balance problems. Intervention delivery can be adapted to the local setting. This manual was being published by the University of Warwick entitled Multifactorial Fall Prevention Manual. Why we need a falls history interview and what is red flags to be considered. A comprehensive fall history interview must be undertaken with every participant invited for the assessment. The purpose of a falls history interview is to identify any predisposing factors leading to a fall, to explore context and consequences of any previous falls or near misses, to provide clues about causation. The profit assessor is trained in a systematic inquiry about falls, including symptoms and contextual factors before, during, and after any related event, including trips and Istanbul. However, during the trial, they didn't found templates or guidance for the types of questions to be included. Therefore, they generated a template list of prefix prompt questions based upon observations of an experienced clinical staff conducting during false interview. The prompt question were produced as an easy-to-use laminate prefix assessor. The aim of a full history interview is to identify intrinsic risk factors, relevant activities, and environmental challenges, any of which may be amenable to modification. What are the red flags? Red flags are the warning signs that referral to a GP or medical specialist is warranted. What are the examples of red flags? 1. Cardiac abnormalities, history of syncope, evidence of seizure activity such as aura or tongue biting. The next one is the balance and gait disturbances. For the balance and gait, time up and go was developed as a basic test for functional mobility. It consists of observation and measurement of the time taken for participants to stand up from a standard chair with arms of seat height 40 to 50 centimeter, walk forwards a distance of 3 meters at a normal walking pace, turn and walk back to sit down to the original sitting position. For the purpose of the trial, they defined deficits as taking longer than 14 seconds on the time up and go, evidence of gait or balance problems of fear of falling was identified during the false history interview. For the vision, they included a simple visual acuity screener using a standard 3M Snellen chart test. The Snellen chart screening tool is used in conjunction with questions about last eye checkup or any changes in eyesight or any visual problems. So, for the eye checkup, they encourage all of the prefix participants to attend their one free eye checkup per annum. For the medication review or medication screen, they conducted full face-to-face medication review, modify, reduce, or stop culprit medications if indicated, provide non-pharmaceutical advice for treatment of chronic conditions. For the foot problems, the prefix participants are screened for any foot problems, including pain, numbness, diabetes, and regular attendance at cryopody or podiatry. They also conduct visual examination to check for bunions, hammer toes, calluses, or nails that may cause pain or gait disturbances. Tests are undertaken for proprioception, big toe positioning with eyes closed, and sensation by brushing a cotton wool ball lightly across both feet, with the sternum used as normative reference. Assessment of footwear is undertaken and advice is given on proper fitting shoes. Example, wide fitting, low heel height, slightly beveled heel, good supportive heel collar, a thin firm midsole to allow sensory input and slip resistance soak. For the postural or orthostatic hypotension, first, let's define what is postural or orthostatic hypotension. Postural or orthostatic hypotension, defined a sustained reduction of systolic blood pressure of at least 20 millimeter mercury or a drop in systolic blood pressure to below 100 millimeter mercury, or a reduction of diastolic blood pressure of 10 millimeter mercury within 3 minutes of standing. The PREFIT participants are screened by asking if they ever feel dizzy or lightheaded if they stand up too quickly or first thing in the morning getting out of bed. Lying and standing blood pressure is taken on all trial participants, regardless of history of dizziness, using a calibrated manual or electronic sphygmomanometer. The radial pulse is also taken for 1 minute. And if there is irregular pulse, bradycardia or tachycardia, ECG has to be taken. During the standing phase, participants are asked to report the presence of dizziness or lightheadedness. Also, symptomatic patients was given PREFIT postural hypotension leaflet that provides advice about changing position, fluid intake, tightening calves when getting up from a lying position. The last one is the home environment. According to them, there is one good quality trial demonstrating that home hazard assessment with a supervised modification program is effective in reducing falls in those discharged from hospital. The evidence suggests that home hazard removal and advice about functional activities is most effective in reducing falls in individuals with visual impairment. It is not prerequisite that a home assessment is conducted for every PREFIT participant. But if there are concerns about the home environment or safety performing activities, or if suspicions are raised during the falls interview, someone reporting repeated trips or stumbles at home, onward referral is then made to occupational therapy or social services. In some instances, social services can cover the cost of home adaptations or equipment. Screening questions include asking about the use of furniture, walking, difficulty getting out of a chair or rising from the toilet, any stairs or steps at home, coping with stairs, using of walking aids. A PREFIT home safety tip sheet is given to anyone who may benefit from simple advice on home safety. For the discussions, one of the strengths of this journal is that this complex falls prevention intervention is currently being tested within the framework of a large clinical trial. This paper adheres to Tidier and consort recommendations for the comprehensive and explicit reporting of trial intervention. Tidier is the template for intervention, description, and replication, while the consort is the consolidated standards of reporting trial. Another strength of this journal is that decision about inclusion of components within the PREFIT MFFP intervention was underpinned by evidence from high quality, which is the Cochrane Systematic Reviews and Clinical Practice Guidelines. To date, based upon early findings from the PREFIT pilot study, the MFFP intervention has been found to be feasible and acceptable to participants and primary care staff. For the limitations, the following are not included in PREFIT falls assessment. Those are detailed tests of urinary incontinence, hearing or osteoporosis risk, and a comprehensive assessment of the neurological or cardiac systems. For the conclusions and recommendations, Comprehensive description of the context and testing of complex interventions is an essential component of robust trial design, delivery, and reporting. The design and development of a complex falls prevention intervention that is currently being tested within a large-scale, pragmatic trial evaluating alternative fall prevention strategies for older adults. The effectiveness and cost-effectiveness of the PREFIT MFFP intervention compared to advice and exercise on the prevention of falls and fractures will be reported at the conclusion at the end of this trial.
For clinical context, the current Morsefall assessment tool consists of history of falling, secondary diagnosis, ambulatory aid, intravenous therapy, gait and mental status. The PREFIT MFFP intervention can be integrated to the current Morsefall assessment tool. Evidence from the multiple systematic reviews suggests that multifactorial interventions reduce the rate of falls, but not the risk of falling. So, the last part of this presentation will be the appraisal of this evidence using the GVI critical appraisal checklist for random control trials. The link of this checklist will be sent through the chat box. Please fill this checklist. The information and answers you will provide will be treated confidentially. Your e-certificate will be sent to your email after completing this form. Or you can scan this QR code. So once again, thank you very much for joining us today. In behalf of Nursing Evidence-Based Practice and Research Council, I'm extending my warmest appreciation to everyone. Thank you.